Dr. Ziad Arabi. Dr. Ziad is a consultant transplant nephrologist working with us at National Guard Hospital. Dr. Ziad is a holder of the American board in nephrology and transplant nephrology from Buffalo. I really would like to welcome Dr. Ziad to give us a talk today on desensitization versus per kidney donation. Dr. Ziad, please. Dr. Ziad, can you unmute your microphone, please?
Assalamu alaikum. Do you see me? Do you hear me?
Yes, now I can, yes.
Assalamu alaikum. My name is Ziad Arabi. I'll talk about desensitization versus paired kidney donation. Just for a second. Okay. 1 in 3 potential living kidney donors is either ABO or HLA incompatible with his or her intended recipient. ABO blood groups are carbohydrate-based. Blood group O is about 50% of the population. Blood group AB is about 5%. Blood group A or B is the rest. Blood group A is divided in A1 and A2. A2 is about 20% of the total A, and it is less immunogenic and can be transplanted in B if the anti-A titers are low, and this recipient will not need desensitization in this case. HLA is protein-based. HLA is inherited in Mendelian manner. And as you heard in the previous talks, that mismatches are more important in renal transplantation, whereas matching and mismatching are important in bone marrow transplantation. Now, these are the most frequent allele and in Saudi Arabia, published by Professor Ali Hajir. So if we take, for example, a recipient with 4 anti-HLA, I chose the most common ones. So this patient will have a PRA of 74%. So that means that he has a chance to get a donor from the public, 26% only. This recipient, for example, he will need 10 to 15 donors to be able to match. And this is difficult, very difficult, if we are dealing with living kidney donor alone. So the patient will remain on dialysis for years. And as you are aware that dialysis is inferior to waiting for a transplant or doing early desensitization. These are the principles of desensitization, and it involves plasma pheresis, IVIGG, rituximab, and you know the rest. Desensitization protocol, this is the principle, no need to go in details. Outcomes of ABO incompatible transplantation in general, the success rate of desensitization for ABO is more than 90%. For example, in Japan, they had success rate between graft survival 96% for the first year, and for 9 years, 83%. Our colleagues in King Faisal, they had the outstanding program for ABO incompatible desensitization, and probably you will hear more about it in the next talk. The risk of HLA incompatible desensitization correlates with the level of HLA incompatibility. You also heard about this in the previous talks. So if you are transplanting patient with positive cross-match, he will have very high risk for rejection. The risk of rejection will be low if the cross-match is negative and no DSA. The outcomes for negative cross-match is superior to someone with positive cross-match. Again, each center has their own cut or threshold for desensitization. In our program, we only do moderate risk and intermediate risk. We avoid high risk and very high risk because the AMR can be up to 30%. Okay, so the AMR in different studies showed that AMR can be up to 30%. So the success rate of desensitization for ABO incompatibility is higher than HLA incompatibility. And that is because we are dealing with carbohydrate as antigen for ABO incompatibility, and we are dealing with a peptide in HLA incompatibility. In ABO incompatibility, we are dealing with T-cell independent natural antibodies, whereas we are dealing with memory T and B-cell preformed DSAs in HLA incompatibility. Again, this early desensitization is superior than waiting on the waiting list. However, with the evolution of paired kidney donation, this one, the paired kidney donation probably is much preferred. Paired kidney donation started in South Korea in 1990. The first paired kidney donation in Europe and US was in about 2000. These two scientists got Nobel Prize in economics because they introduced the idea of matching, complex matching. It is the same principle for paired kidney donation and the matching programs for fellowships and residency in US. So now paired kidney donation is about 16% of the total transplant in US. Paired kidney donation programs in US, there are several programs, and there are also several programs in different countries, including Saudi Arabia. Paired kidney donation can be simple two-paired exchange, or can be domino paired kidney donation. In San Francisco, for example, they had 9-way kidney swab involving 18 surgeries in 2 hospitals. There are several examples of longer chains. For example, in 2012, this is a chain of 30 pairs. And this is another example of a chain of 34 pairs swab between 26 different hospitals over the course of 3 months. Now, the question, desensitization versus paired kidney donation. So if you have a patient who has a low level DSA, do you send him for paired kidney donation, or do you send him for, or do you perform desensitization? To answer this question, a few months ago, we sent a survey internationally through the American Society of Transplantation, American Society of Transplant Surgeons, and ERA EDTA. We asked several questions, and the top 2 of them were related to this topic. We had 239 respondents from 29 countries. Half of them were nephrologists, and the rest were surgeons. The first question was, if you have a patient with a DSA of less than 1,000, what do you do? Do you transplant him? Do you refer him for paired kidney donation? Do you do desensitization? So about 45%, they said, we'll send him for paired kidney donation. So again, the level of desensitization, a threshold for desensitization or sending somebody for paired kidney donation varies among centers. Now, the second question that we ask in our survey, if you have an incompatible pair, do you do desensitization or paired kidney donation? As you could tell that the vast majority said we'll send this patient for paired kidney donation. The acceptance of ABO incompatible pairs among countries vary. For example, in Japan, ABO incompatible kidney transplantation is 25% of the total living kidney transplantation. However, paired kidney donation in US, however, paired kidney donation has largely made this practice unnecessary in other countries like US. Now we'll move to a second topic, which is the co-compatible pairs. It is the pairs that can be transplanted without desensitization or paired kidney donation. However, the recipient is at risk for rejection or graft loss if he is going to be transplanted with his originally intended donor. For example, if you have a recipient with a low DSA, that like the example that I gave earlier, a recipient with low DSA and negative cross-match. Another example, if you have a recipient with re-exposure to an HLA antigen from previously rejected kidney, or a recipient with CMV negative, but his donor is CMV positive. Now, enrolling compatible pairs in paired kidney donation offers a better match, which leads to a better outcome. It helps also other patients who are incompatible. Now, living related donors, they have typically 2 to 3 mismatches, whereas the living unrelated donors, they have 4, 5, or 6 mismatches. Does this matter? There's some hint that it is less important than the previous years before the days of Prograf and CellCept. However, mismatching is still important, and it is more important in living kidney transplantation than the diseased donor kidney transplantation. In green, it is the line that has a ratio for failure for mismatching in diseased donor. The issue in diseased donor kidney transplantation, the graft does not last long to enjoy the benefit of good matchability. However, in living kidney donor, the graft lasts about double. So the matchability is important, especially in living unrelated kidney transplantation, which the line is in blue. Now, does HLA matching matter in the modern era of renal transplantation? Here are several studies that showed it is important for long-term survival and retransplantation. And I will just highlight one of them. Here in this study, it showed if you have poorly matched living donor, the outcome will be inferior to a good matched diseased donor, according to this study. Now, the effect of age and mismatching in diseased donor, both are important. But in living kidney transplantation, the matchability is more important than the age of the donor. The matchability the difference between 5 mismatches and 6 mismatches is not a big deal. Now, we'll move to a next topic. It is about shipping of kidneys in paired kidney donation. The outcome is generally good, and there's some evidence that can cause mild increase of delayed graft function, about 1.8%, in spite of shipping the kidneys for 1,600 miles with cold ischemia of 12 hours. The outcomes for at 1 year was excellent. Similar finding in different study. So this will bring the topic of paired kidney donation at the city level, state level, nation, international, and global. However, it is important to keep in mind the limitation and the potential for human error that can happen even in simple kidney transplantation. Next topic will be advanced donation and voucher for future kidney transplantation. For example, you have a teacher who is a donor, he want to donate in the summer for his recipient to get his transplantation at a later time. Now, the outcomes of paired kidney donation, it is excellent. The graft loss is 1.6% only in the first year, with primary non-functioning kidney of 0.5%. Our colleagues in the MAM, they presented their data also. They have an outstanding program for paired kidney donation. They had 62 pairs with 3 unrelated donors. 25% of their recipients were listed because ABO incompatibility. 75% of their recipients were listed for HLA incompatibility. They were able to transplant 37% of the listed recipients. Their longest chain was 7-way domino chain. They had to use desensitization of 10 of 23 patients. The delayed graft function was 1, AMR 2, acute cellular rejection 1. Graft function was good for 6 to 18 months. Unfortunately, 1 patient died 8 months from refractory sepsis. So that will bring their patient and graft survival to about 95%. So they were able to transplant 1/3 of their pairs by a combined approach of paired kidney exchange and desensitization. And the majority of their recipients were transplanted without the need of desensitization. However, the matchability in subsequent runs of paired kidney donations will go down because in the first early runs, you will be able to transplant the easy ones, and the difficult ones will remain on the waiting list for subsequent runs. For example, this study from US, in the first run, they were able to transplant. They listed 38, they transplanted 4. In the 5th run, they listed 34, they transplanted 0. So the challenging pairs for paired kidney donation are those with donor A and recipient O, and recipient with the high PRA more than 90%. Moving to the cost of paired kidney donation versus desensitization, the average yearly health cost for PD. These numbers from US, and I got them from different references, so they are not 100% matching, but just to get an idea. So the yearly cost for PD is $130,000. For hemodialysis, $170,000. For kidney transplantation, for the first year, it will cost $440,000. And medication and rejection medication afterward, it will be $17,000. Desensitization will add more costs, about $33,000 for the hospitalization, and there are some costs for the subsequent years. So if we assume that the half-life or the average life for a kidney transplant is 10 years, the cost for hemodialysis for 10 years is $1.7 million. For PD, $1.3 million. For desensitization, $0.5 million. For transplant without desensitization, $0.4 million. And transplant through paired kidney donation, it's somewhere between $0.4 and $0.5 million. So the cost for paired kidney donation versus dialysis, the cost of dialysis is about 3 to 4 times more than performing renal transplantation with or without desensitization or through paired kidney donation. In summary, transplantation after desensitization for HLA incompatible or ABO incompatible or through paired kidney donation reduce waiting time with a dramatic impact on the survival of the incompatible recipients. The success rate of desensitization of ABO incompatible is high, but the results remain center dependent. A majority of transplant nephrologists and surgeons would prefer to refer an ABO incompatible for paired kidney donation than performing desensitization. The risk of AMR is high for HLA incompatible desensitization, and this depends on the threshold of desensitization, which varies among centers. Many nephrologists and surgeons would prefer to refer HLA incompatible pair for paired kidney donation than desensitization, even for a low-level DSA. Paired kidney donation is a growing alternative for desensitization. Paired kidney donation can be performed alone or along with desensitization. Paired kidney donation avoids unacceptable antibodies and may decrease the number of mismatches. Paired kidney donation provides alternatives for co-compatible pairs. About 1/3 of incompatible pairs can be potentially transplanted by a combined approach of paired kidney donation and desensitization, and the majority of these patients require no desensitization. Paired kidney donation at the city or international level is likely to increase the matchability rate. Shipping of graft during paired kidney donation may increase the risk of delayed graft function. However, the 1 year and the 1 year graft and patient survival remain excellent. Paired kidney donation is very cost effective. Be prepared for the logistics of paired kidney donation, and thank you.
Thank you so much, Dr. Ziad. I really enjoyed your talk. And the floor is open for questions, please. No more questions? I would think.
Yes, I have one question, please.
Yes, please. Yes, please.
Just what about your experience about non-directed donor to start chain? Any experience here in the kingdom, and how do you approach that, the non-directed donor?
We do not have a paired kidney donation in our hospital. However, our colleagues in Dammam, they reported in their study, they have 3 undirected donors in their chain. So we have undirected donors all the time, but in our program, we don't have paired kidney donation at the present time, but maybe in the future. Of course, having unrelated donor donating for the paired kidney donation, that will facilitate the whole chain.
Any more questions, please? If no question, yes, please.
Dr. Ali Hajiri, if I may add a comment, I'm Hassan Al-Eid from King Faisal. I enjoyed Dr. Ziad, very nice talk and a very good summary. On the same question, we had one non-directed altruistic donor who came and worked up, and then we initiated paired kidney chain, and out of that 1 donor, 7 transplants were achieved in 1 week. So definitely the outcome of the chain is by far much more than the swab or the closed exchanges.
Wallah, we are very proud of this, Dr. Hassan.
MashaAllah.
I must say that the efforts of King Faisal and King Fahad Medical City in Dammam are so great and recognized in their effort to do the per kidney donation. And I hope at one point of time we can have all centers connected together and doing it as a one pool, inshallah.
Inshallah.
Any other question, please? If there's no question, I'd just like to remind you that we will be having a break from 5 to 5:20. We'll resume 5:20, inshallah, with Dr. Ashraf Dada. And we have, as I said, the CMEs will be emailed within 10 days. They are ABHI accredited CMEs. And I hope you are having a good time and enjoying this meeting and on to start an advanced level of transplant immunology course, inshallah. Thank you for your time, and I'll meet you at 5:20, inshallah. Assalamu alaikum.